So I'll wait until you guys tell me. Should I practice it?
12:15.
Okay.
Should I go? Yeah.
Yeah, I'm just gonna So thanks for coming, everybody. I'd like to welcome Dr. Brooke Miller today. Dr. Miller has put together a very comprehensive eye emergency talk, so hold on to your seats. Get ready. She's head of the University of Rochester School of Medicine and completed her ophthalmology residency at the University of Rochester Medical Center. And Brooke and I were just discussing before she moved to Maine, she was a physician at Upper Medical Center in their ophthalmology clinic, where she taught resident ophthalmologists. And currently, she is part of the Maine Eye Center group here in Portland, and you guys are going to be moving.
Yeah, I think we're going to be your neighbors, so yeah. Well, we're going to keep both. So we have like 15, almost 18 doctors, including the optoms. We're going to be on Marginal Way at the old yes, yeah, I think it's going to take a few years, and our ASC will be there. Yeah. Yeah, so be nearby. Yeah, I think we'll still have our Lowell Street office, too. There's just too many.
They just can have a walkway.
Yeah, especially if it's a winter like last winter, so, yeah. So, great. So I'm Brooke. I'm one of the eye doctors at Maine Eye Center, and I'm a general ophthalmologist, and I work primarily in our urgent care department, which we opened up a little over a year ago. So we cover Maine Med all the time, ER and inpatient consults, but we also see patients referred in from groups like Intermed or Quick Care. Somebody's got like a piece of metal in their eye. So it's pretty fun every day. There's something different that kind of shows up. So when Dr. Clem and I were talking, I was trying to think of what might be the most high yield. So we thought maybe some urgent stuff that you might see that might need to come to us, or a few of these are a little higher acuity that might show up to the ER rather than at your office. And I tried to think of cases that I'd seen that we'd kind of shared patients overlapping, but if I couldn't include everything in the interest of time. So if there's some, feel free to jump on or ask a question, or at the end if there's something I didn't get, just holler. So I think that's it. So we're going to go over some anatomy, eye history, and physical. We'll go over adult peds and OB cases because I think there's all those disciplines represent maybe some more. And then at the end, I really want to get to the end. There's like three. Luckily in ophthalmology, we only have like 3 actual true emergencies, but they're pretty important. So I'll try to get to those at the end, and then we'll go over any questions that you have. So this is a general anatomy slide. Is there I didn't even ask, is there a pointer on the, I'll just walk up here, that's fine. So,
There should be a pointer on the
oh, yes, we like lasers, so. It doesn't work.
You can't do LED on LED.
Oh, yeah, that makes, okay, so we'll do it the old-fashioned way if we need to. So we've got the external part of the eye, and there's an exam slide later we'll go over, but a few key features I want to point out in the external part of the eye. Everything else is the conjunctiva, which they don't have labeled here, but that's highly vascularized. So any kind of inflammation, infection, the conjunctiva is going to be injected. The sclera is under it, and that's not as vascular. So any red injected eye is something is, irritating it, infected, inflamed. Next is the cornea, and this is avascular. So if you ever see any blood vessels, it might be hard in the clinic, but if you ever see any blood vessels on the cornea, that's highly abnormal, and any lesions or white spots or bumps. This cartoon, that's a light reflection. In our office, we use a slit lamp. If you've ever had an eye exam, you remember the light beam. So, and that typically should be clear and nice and round. If the reflection is bumpy or irregular, that tells you there's something wrong with the cornea, and there's a few examples coming up of that. Next is the anterior chamber, which is right here. The aqueous humor, which is filled with glucose and nutrients to help nourish the eye. Drains, is made here in the ciliary body, which is part of the iris, comes forward and then drains here in the angle, which is between the cornea and the iris. And this is important in an emergency situation if somebody has angle posterior glaucoma or the pressure shoots up very high in the eye. So we'll talk about that later, but this is the angle of the eye. Next, the lens, where if you had a cataract, that was developed there. And then this is the vitreous jelly, which is optically clear and it's very sticky. And then next, the retina, which is the neurosensory retina, has 9 layers, including the photoreceptors that help us see. And behind that is the choroid, and that's one of the highest oxygen content areas in the whole body. Just the oxygen circulation is extremely high there, just to help keep us seeing throughout the day. It's really high metabolic rate in the retina. And lastly, the sclera, which is the thick collagen material, and then the rectus muscles to help move the eyes around. And and the optic nerve, didn't mean to leave that out. The central retinal artery and vein travel from within the center of the optic nerve. And you know what, let me find, I wonder if that slide, let me go back here. And then the retina, this is really hard to see unless you have our dilating eye drops, but I thought I'd go over it, we'll go over it, and sometimes it is, you can see it with a direct ophthalmoscope in the office. So basically you've got the optic nerve, and we often talk about cupping or the cup to disc ratio. So the cup is the central part in the middle, and if somebody has increased cupping, basically this optic nerve, which is round like a donut, looks like there's been bites taken out of it, and that could be a sign of damage to the optic nerve, say if somebody had glaucoma. And then you've got the arteries and veins. The veins are bigger than the arteries if you're looking in at somebody's eye. And then the macula, which is really this whole central area here, and this is responsible for most of the sight that we have throughout the day. And the fovea is really tiny. It's about 500 microns in size, and it's the highest area. Most photoreceptors are concentrated there. All right, so for the history, probably pretty similar to what you do in your office, but I read this neat little RSVP mnemonic, but basically redness. So redness is not normal, sign of inflammation, infection, irritation. Light sensitivity, you can ask patients about that. If somebody's light sensitive, they might have like an iritis or a uveitis, or else if folks have gotten hit in the eye or a scratch on the eye, they can often be really light sensitive. So light sensitivity is sort of a big red flag. Vision, find out if it's decreased, did they wake up and it was all of a sudden, poor, or has this been going on for a long time? And then any pain. If somebody describes like a sharp pain or a foreign body sensation, that's usually something in the front of the eye or the cornea. And then past ocular history, most people know this, but some patients don't really know their eye doctor or what eye drops they're on, but good questions to ask. And then also finding out if they're contact lens wear. Contact lenses, we'll go over pretty soon, is a big risk for getting an infection or an ulcer in your eye. And then relevant history, some of the bread and butter stuff that probably we all see every day are come up. And then any autoimmune conditions overlap with us. A lot of folks with autoimmune conditions, ankylosing spondylitis or Crohn's disease can have iritis and problems in the eye. Exam, so these are kind of some of our basics that we'll go over. Vision is one of our big vital signs of the eye, and often in inpatient consults, I had one the other day, the patient said, why do you have to check my vision? It's fine, but actually this is one of our key things, and it's really easy to have it done incorrectly, even in our own office. I'll be typing my note and I've memorized the chart, and then I look over and the patient's occluder is out by their ear. So the way to do it is always have the patient have their glasses on. It doesn't tell anybody anything if you take their contacts out or their glasses out to check the vision. So keep the glasses on, and then one eye at a time. And if you don't have like the distance chart, the Snellen chart, if you have a little hand card, that's fine. Even there's apps you can Google, that's fine. And that's the Jaeger, the up-close system. And you want to test one eye at a time. In this example, this lady's, kind of peeking, which probably more happens in the pediatric population, but it happens to everybody. So if you have an occluder or even like a magazine in your office and have them block their eye. Another key feature, if they're using their hand, this sounds really silly, don't have them, sometimes people are trying really hard to be excellent patients and they're like pressing on their eye really hard and then they go to check the other eye and they can't see because they've sort of, like if you look, you've got a sleepy leg if you cross your leg too long. So don't let them push on their eye when they're holding their hand to check the vision. And then the pinhole we do in our office, probably that's not here, but there's little holes that in the occluder that can help us eliminate any refractive error. So if somebody does forget their glasses, you can even make one of these with a piece of paper and put a little hole in it and hold it up. And it basically helps to focus the light on the retina if they don't have their glasses with them. The pupillary exam, this is busy, so we won't go into all this, but the pupillary exam is also really important. It's extremely objective. I had a patient yesterday that was 13 and really sweet, and anyway, she had a problem and ended up being fine, but one of the main things that we knew, her eye was fine because her pupils were normal. So basically, when you're starting to look at the pupils, you first note if there's any difference in size, especially if they're, coming in with a headache or saying their lid is droopy. And what we look at really carefully is something called the relative afferent pupillary defect. And this sort of assesses the relative strength that each eye has in terms of the light signal coming in. If somebody has this abnormality, an RAPD or an afferent pupillary defect, it really shows there's a problem in one eye. This can be like optic neuritis. It could be a tumor pushing on the eye. They could have had a stroke to their eyes, a vein, retinal vein or artery occlusion, or if they have a really large retinal detachment. And this is a busy slide, but the main thing to remember is that these little red and purple colors here are just showing that where the light is received, and these fibers, these light fibers cross at the chiasm, many places. And so basically the eye is innervated equally in terms of the light signal that it is getting. And this will make more sense in a second. For the pupillary exam, you want the patient to look far away. One of the responses when we look up close is our eyes constrict and the pupil becomes very small. So have the patient look at a distance target, and you want you don't want a diffuse light like a flashlight if you have, something that's smaller like a pen light, or maybe even the light function on your phone might work. And this makes more sense. So a normal eye, what you're going to do, you shine the light, and this is if you're looking at the patient. You shine the light in the right eye, and there's both eyes should constrict. You can play with this, if you got a resident around or a friend. It's kind of fun. Dimly lit room. I think it's fun. Practice. Shine the light in the right eye, and the left eye should constrict as well because of the crossing of all those fibers. Now, the swinging flashlight test, you might remember in your neurology rotation, we're kind of swinging back and forth. When you swing from one eye to the other eye, there should be an initial constriction, and this is normal. This is an abnormal eye, so you swing to the right eye and they both constrict, but now you swing it to the left eye, and this eye is seeing less light relative to the other eye. So instead of having an initial constriction, this eye will dilate, and then you go back and they both constrict. So it's tricky, and it takes, even as a resident, it takes people years to really get it. But if you're not sure, Google swinging flashlight test in your office or send them to us, but it's an important part of the exam. The eye pressure, normal pressure is about 15. As high as 22, 25 is fine. And probably this is something that it would be done in the ER or at our office. But just normal pressure is 15, and we'll go over some cases with this. The exam, so looking at the eyelid, you want to look for, is it drooping? And if you look at yourself, assuming if your lid is normal, it's going to be kind of sitting right flush with the top of the eye. It might hang over a little bit. If it's really far down, you could be having ptosis. There could be some swelling of the lid. Look for any bumps along here. Squamous cell and basal cell are pretty common. Basal cell more around the lid. Conjunctiva, is it red? Is it not red? There's different patterns. If you have a patient that has sort of a sectoral wedge of redness, that can be a sign of something called episcleritis, or if there's a pinguecula or a little bump on the eye, those can get red and injected. The corneal light reflex, so this is, again, this is nice and sharp and clear. This tells you that the surface is fine, and then iris and lens. The fundus exam is hard. It's hard without the drops, even for us. Just to have the patient, again, look far away. Otherwise, their eye is going to constrict and the pupil will be really tiny. So have them look at a distance target. And you're really just trying to find the optic nerve. The optic nerve is nasal. So what that means is that you want to come in to the patient from their temporal side, and you'll have a better chance of finding the nerve. And the way that you know if you're getting closer to the nerve is all these vessels will start getting closer together. So kind of follow the vessels until they get more crowded and you should hit the nerve. The other thing too is I tell patients I'm going to get really close to your face because otherwise you're getting in really close and they're like wondering what's going on. And I also rest my hand on their forehead because the last thing you want to do is bump their eye with that direct ophthalmoscope and cause a corneal abrasion. So just a few positioning things there. All right, so we're going to go over some common adult problems, but actually these all can affect all ages, kids, all ages. So foreign body sensation, 30-year-old male who's clearing brush outside, a stick hit him in the right eye. He feels like something is in his eye and he's got blurry vision. And later on he starts noticing some light sensitivity. So the eye is diffusely injected. You can see the corneal light reflex is kind of off. And there might be a little something hazy going on here. So this is a corneal abrasion. You probably have seen this in your office. And it's really common. Any minor trauma can do it. And what it does is it takes off the injury causes a loss of the top layer of the epithelium. Now the cornea is one of the most highly innervated parts of the body there is. And if any of you have ever had a corneal abrasion, I mean, this really hurts. So people will be in a lot of pain. They'll feel like something is in the eye. There might be some lid edema. The same nerve that goes to that upper lid also goes to the cornea, so the lid might be swollen as well. You want to put in some fluorescein. Again, I don't know if you guys have Woods light lamps in your office. So, and there's these little orange fluorescein strips. Now, the best thing to do is get these things wet. If you put it in dry, if there wasn't a corneal abrasion there before, there will be one after. So, which I've done in, first week of residency on a screaming little kid. So the best thing to do if you have a cooperative patient is put the drop on the fluorescein strip and have the patient look up, and you can kind of paint it on the white part of the eye, the conjunctiva. That doesn't, if you play with it yourself, if you touch the white part of your eye, it doesn't really hurt. So have them look up. If it's a kid and it's a difficult exam, you could even kind of dribble it, get it wet, and kind of hold it over their eye. They'll eventually scream and open their eye up, and the drop will go in. Just quickly to distinguish this from an ulcer, these can look similar. An ulcer is basically an infection in the eye. We'll go over that soon. And they both can feel like something is in the eye. Some people, too, will say, well, I slept in my contacts and I took my contact out and I think I scratched my eye. But that's actually probably an ulcer in their eye. And the way to tell the difference, and I picked a little bit of a tricky picture here, and you might be able to tell this in your office, but you can see there's some white, if there's like a little white dot there, that's pus, that's an infection cell. So that would help you kind of look at the difference there. So this would be, you want us to see this patient that same day. And then, so treatment, if it's a clean kind of injury, something like a polytrim or a Cipro drop is fine. 4 times a day is the most you need. You'd never need to do any drop more than 4 times a day in this situation. If it's kind of a dirty infection, the guy was out with a stick in the woods, I would do something like a Vigamox, or the Cipro is fine. Some people, another way to do it is to put in some ointment and pressure patch the eye. That I don't like as much because patients, if they suddenly lost vision for some reason, their eyes patch and they don't know it. But for a few days, that can provide a lot of comfort. And then if it's a small abrasion, they might need follow-up with us, or if it's bigger, have them see us. If it's large like this, we actually put a special contact lens on the eye to help it heal faster and to help with pain control as well. And then these can often, sequelae, these can open up spontaneously 10 years down the line, and that's called a recurrent corneal erosion, and that's painful. If you don't cover with an antibiotic and it's large like this, very rarely, but it could turn into an affected ulcer. We kind of went over some of these. Other things, if the trauma was pretty big, like I've seen a lot of 3-year-olds are out in like at preschool and something like hits them in the eye. Look for a hyphema. Just look for a little red line in the anterior chamber, and you can see this pretty easily in the office. If there's some really big trauma at the same time, they might have an orbital fracture or some kind of problem in their retina. Make sure you look for a foreign body. This is like a person with a little piece of metal there. And then also ruling out something like this is a herpes simplex ulcer, and this is a bacterial corneal ulcer. So if there's something on the cornea, and we should take a look. All right, so next, any questions? All right. So 21-year-old contact lens wearer, she comes in with intense light sensitivity, the eye is red, it's blurry, she sometimes sleeps in her contacts, and she took out the contacts, but now the pain is worse. So you can see again, diffuse injection, this corneal light reflex is terrible, and there's this white spot in her eye. So a lot of times people will say, oh, I slept in my contacts, I think there's a piece of contact that's stuck right in the center of my eye, but that's actually the ulcer. So there's a large differential diagnosis of the red eye, and it's confusing to everybody, even to ophthalmologists. You get a lot of people coming with red eye, and it can be anything from as simple as blepharitis to, you know, angle closure glaucoma or uveitis. So there's a long list of different things that can cause a red eye. That might be another talk down the road, but so this is a bacterial ulcer, and I've had a lot. I don't know who. There's a lot of folks from Intermed that have sent us. You know, I think these people often present first to you guys, and then they come to us if they haven't had an eye doctor yet. So basically, there's many different kinds of we call these ulcers, but of an infectious keratitis. In the United States, it's usually bacterial. In Maine, it's bacterial. Somewhere that's warmer, like in Florida, they have a lot more of fungal ulcers. In the United States, this is usually due to contact lenses, and the number one cause is a Pseudomonas ulcer. You can also get this from trauma. If somebody used some old eye drops and put them in their eye, and other corneal problems, if somebody's cornea isn't working right, they can get these as well. And sometimes this just happens. There's some organisms like Neisseria and Pseudomonas that can just invade an intact cornea randomly. And this, I should just show this, the ulcer, unlike a corneal abrasion, kind of eats away deeper into the cornea. So it actually can be thinning of the cornea, and if it's a really bad ulcer, it can actually perforate or cause a hole through the cornea, and then they need a corneal transplant. So ulcers are definitely an emergency, and they'll be injected eye, there'll be a lot of pus, there'll be a lot of, you know, if you did the Woods lamp, there'd be a big, what looks like a big ulcer or loss of epithelium. And there might be a hypopyon or a layering of white blood cells at the bottom of the anterior chamber. Right here, you can sort of see a white line. So that's like an early hypopyon. And then this is a small ulcer. A lot of times they're pretty small, and but they can also cause big problems. So these are true emergencies. At our office, we'll usually culture them to see what grows back, and then we'll start them. If it's a small ulcer like the one on the bottom, we'll just do Vigamox every hour. If it's a big one, they'll get fortified compounded antibiotics, tobramycin and vancomycin, every hour, but we alternate it every 30 minutes. And we tell patients or their spouses, like, wake up in the middle of the night and open their eye and, you know, squirt it in. So these can cause a lot of problems: perforation, scar, corneal transplant. So definitely something white on the cornea, let us know. This you guys probably see a lot: a 71-year-old male, diabetes, a new rash on his face, and he feels like something is in his eye. One of the important things I want to point out about this slide is he's got some bumps here on his nose, and that's the Hutchinson sign, or basically, you probably know this is doctor. So the nasociliary nerve innervates both the cornea and the tip of the nose, just in terms of the dermatomal distribution. So if you see that, there's up to an 80% chance that the eye is going to be affected as well. And when these patients say there's something in their eye, there's an opening in that epithelial layer, and they can have a lot of different staining patterns on their eye. And, you know, rarely would it affect the retina at the same time, but if they're immune compromised, it can, and you can get a retinal necrosis. So this is obviously not a normal retina, and all this white is just necrotic tissue. There's bleeding. This is bad. You know, they would get admitted, and we actually have implants. We have antiviral implants that go in the eye and we do intravitreal injections to try to calm this down. So they should still see us. The main treatment is similar, you know, acyclovir and Valtrex or Valtrex, and then you want to give them an antibacterial coverage. Some of these patients end up developing a type of glaucoma or high eye pressure in their eye from the inflammation cells, what's called a trabeculitis. And then some people have a different problem, and we treat either of those with steroids or eye pressure lowering drops. And this is a bad agent. I mean, it's common, and people keep coming back to us. They have scarring, and this can cause double vision with a scar and corneal transplant. So definitely we should take a look at these. All right, so we're going to move a little bit to the back. Oh, yeah, of course, yeah.
When we see shingles around the eye,
yeah.
No, I sense it's not red, and it's not itchy. Do you want to see it?
I don't think so. I mean, you could tell them if your eye starts to feel scratchy, let us know. It's usually, definitely if they have the Hutchinson sign or anything like that, and it's probably good to have us take a look, because sometimes this trabeculitis or the iritis related to it, that can happen like a week to 10 days later, even if they're on antivirals. So it might not be a bad idea. Or if the patient totally, if the patient is reliable, I would just tell them to call you back if their eye feels scratchy, or you can give them our number. That's fine. Yeah. Any other questions? All right. So 63-year-old male saw a few arcs of light in his peripheral left vision 4 nights ago, and they're better now, but now he's seeing some cobwebs. He's had no trauma, and then, sorry, this must have cut off, but he's myopic. He's a -5. And I should say, a lot of times patients will complain of a problem in their left. They're not sure if it's one eye or both eyes, or if it's the left side of their vision or their left eye. So try to ask them, if you close one eye, did it get better? Do you really think it was on the left side? Or, checking a confrontation visual field will help with that. But it's pretty common to not really know which eye or which side, and that's okay. So differential diagnosis for flashes and floaters would be, most common be a posterior vitreous detachment, where that jelly of the eye separates from the retina. A retinal tear, a retinal detachment. It could be a migraine. Migraines usually present with like a positive visual phenomenon. So people will say, there's kaleidoscopes marching across my vision, and I then had a headache after. So positive visual phenomenon with colors, that usually lasts less than 40 minutes or an hour, more commonly a migraine with both eyes. And then very rarely a uveitis or floaters in the back of the eye or a tumor. So this patient had we call it a PVD, or posterior vitreous detachment. This is really common, but it can lead to really bad things. It can lead to a detached retina and blindness would be the most feared thing. We see this every single day coming in with the floaters. So what's happening is this sticky vitreous jelly separates off from the neurosensory retina, and sometimes as it separates off, because it's so sticky, it will pull a piece of the retina with it that then causes a tear in the retina, and I'll show you a picture of that in the next slide. Risk factors, everybody, the statistic is like 80% of people by the time they're 80 have this, so everybody gets this at some point. And it can happen in younger folks if there's been an injury to the eye. If you're myopic or nearsighted, you have a higher chance of having this happen. Eye surgery can definitely cause a risk for this. So on exam, again, this will be hard in the office, but you can see if the main floater that actually we see is right in front of the optic nerve, and it's called a Weiss ring. And so there's a little circular line here. So you can try to look in the office to see that, and that's there pretty much almost 100% of the time. Just the way that the vitreous pulls off the eye, the big floater is right in front of the nerve. Then we see them within 24 hours, and we look for tears. So this patient, there's a few little horseshoe tears here. And what happens with a tear is that it's an opening, and the vitreous jelly, which is liquid, goes into the tear and pulls the retina off, almost like if you had water damage to some wallpaper and it kind of bubbles and pulls away. That's the same idea as a detached retina. And if there is a tear, they get lasered. This is bigger, so this person ended up probably having a surgery in the operating room. So definitely we should see these within 24 hours. So there's some pediatric eye problems. Other peds people here? Are there? Awesome, okay. So this is, I know this patient probably looks younger than 5, but I like the picture. So, 5 months old, I'm sorry. This looks like a younger than 5 months old. So 5 months old comes with mom, feels like the left eye waters a lot. He also seems to close his eye outside in the sun. He was born full term, vaginal delivery, no forceps delivery. And on exam, you can probably see the left eye, it's kind of hazy. The corneal diameter looks bigger on this side, and the light reflex, there would be a blurred light reflex. And if you just were in your office and you wanted to try to assess interocular pressure, if you gently kind of, they won't close their eyes to you obviously, but if you kind of gently palpate along the top of the lid, you might feel firmer on that one side there in this patient. And I should say for checking vision in little guys, you can still, you want to cover one eye at a time if they'll let you, and try to see if depending on their age, either follow your hand or wince to light if they're really little. So you can still try to get their vision. So this is a large differential diagnosis. So for tearing, the most common thing that you'd see is a nasal lacrimal duct obstruction. This can also be from congenital glaucoma. It can be from abrasion. Trauma, if it's like a dog bite, which obviously that patient did not have, but if it cuts the tear duct system. A cloudy cornea, this would be more rare, but if somebody had a forceps delivery, it could actually traumatize the cornea and cause it to swell. any kind of infection, glaucoma again, and then some more unusual things. So this patient ended up having pediatric glaucoma. There's a few different kinds depending on what age they are when they present. It's usually sporadic. There are some genetic associations. It's usually bilateral and in males. And this has a little bit of a guarded visual prognosis for sure. And it's thought to be just a developmental anomaly with that angle. And the clinical triad, like on a boards question, would be they'd be tearing, they'd be light sensitive, maybe they'd be squeezing their eyes a lot. So this can actually, even though most of the time kids will come in tearing because that valve of Hasner hasn't totally developed yet, if you see any red flags on the eye, I mean, look carefully for any increased corneal diameter. You can try to just gently touch their eyes. Or if you're not sure, just have the only pediatric eye doctor in the state is Dr. Berman, who's with us. Just have him take a look because you don't want to miss that one glaucoma because it presents with tearing. So, you know, the exam, there'll be some cupping. This is the optic nerve. It's, you know, very cupped here compared to the normal eye. And there'll be some stretch marks on the cornea here from the pressure building up and causing the eye to stretch. And it's really a surgical treatment. So just something to keep in mind. This can be any age group, but I put it in the pediatric section. So 12-year-old male, he's got 2 to 3 days of increased left facial pain and redness. He can't open his left eye. Now he just doesn't feel well. It hurts when he moves his eye around. He's had a recent sinus infection. You know, on exam, he looks like, you know, he's got a cellulitis. His vision is a little bit decreased on the left. I apologize for the ODOS. It just didn't fit, and I couldn't bear to write down right eye, left eye. So the vision is down, and the left eye doesn't move all the way. And the one thing here, this is where you really want to look for that pupillary defect if you could. Because if you think about infection, and we'll go over a slide in a second, but the orbit is surrounded, it's surrounded by bones on all sides. So anything that's going to cause some congestion or swelling is going to push on the optic nerve, which will cause ischemia and then permanent optic nerve damage. So some of these signs, you know, we'll go over them in a little bit, but you want to not have the optic nerve be compromised. So, you know, cellulitis, this could also be in adults, you know, Wegener's or sarcoid. Cancer, you know, neuroblastoma presents with some skin discoloration around the eyes. Trauma, allergies. So if it's superficial, it's really in front of the septum, and the septum is right here, and this kind of separates the soft tissues in the front from the orbit in the back. And usually if there is an orbital cellulitis, it's extended behind the septum, and most commonly from the lamina propria, which is really, really thin from a sinus infection. I guess I'd maybe defer to the ID guys here, but our literature says that kids under the age of 9, it's usually due to one organism. Kids over 9, it can be polymicrobial. Let's see. So findings, like we were talking about, anything that's sort of pushing on the nerve or crowding out the orbit. So the eye doesn't move well, the vision will be decreased. The eye might stick out more. The pupil will have that pupillary defect. And, you know, if you check color vision, they couldn't see colors as well. And it's really a clinical diagnosis. And treatment, you guys do this more than us, but if it looks like it's orbital and they're unwell, then they would get admitted. And usually with the younger kids, at least what I've seen, they're doing MRIs, not CTs, just for the radiation risk. And that would be if the patient wasn't getting better. And, you know, you look for something like this is a picture showing a little subperiosteal abscess. And there's criteria for our oculoplastics colleagues about when they would drain that versus watchful waiting. So this can have bad outcomes, so we take this really seriously. And you guys are great in helping us out with all the antibiotics and that kind of thing, so we appreciate that. So I think for our last pediatric slide, it's a short one. So this patient comes in and mom thinks there's something funny with the right eye and otherwise normal, and you can see a little bit of a white reflex here, a leukocoria. And the best way to check for this, and you guys are awesome at it, you know, is using the direct ophthalmoscope. And it's hard with those little guys to get them to look straight on. Oftentimes there can be mucus, just normal secretion, and that can look like something is blocking your light reflex. So one thing to do is to try to blink for them if you can kind of clear it for them or move their lid up and down if they let you tolerate, to move that mucus out of the way, because a very, very small cataract can actually look like a little piece of mucus could actually be a cataract. So try to block it in front of the way, or vice versa. So there's a large differential. We won't go into it. Most commonly, if you really did have a leukocoria would be from like a congenital cataract, but you wouldn't want to miss a retinoblastoma. Kids that have had a history of retinopathy prematurity can have retinal detachments, so that's something to keep in mind. And then some other infectious etiologies as well, and some other unusual retinal conditions. So just something that's important. And okay, some OBI are there any OB folks? Oh, right. Okay, good. So some of that was general OB, but we'll do a few things here. So we've got a 24-year-old female, 29 weeks pregnant, and she's got worsening vision in both eyes. She was seen in the first trimester of ophthalmology, but she was lost to follow-up. She's got out-of-control diabetes, and she has a history of non-proliferative diabetic retinopathy. And we have a whole categorization system, but she has almost the proliferative kind, so it's not good. So her vision is a little bit decreased in each eye. Her pressure is fine. There's no neovascularization in the front of the eye, but in the back of the eye, she's got, you can see some bleeding at multiple layers of the retina. There's a vitreous hemorrhage. There's some interretinal hemorrhages, and there's some exudates here. So she's got proliferative diabetic retinopathy. So this is actually the most common presenting ocular condition that can be worsened by pregnancy, and we definitely see this a lot. And actually, this can get worse even after they've delivered the baby. So definitely, like in this patient, you know, if we could get her to come back after she delivered, it might still be getting worse. Risk factors, they make sense, you know, longer duration of diabetes, poor glycemic control, and then any coexisting hypertension or preeclampsia. And then pathophysiology, it's just, there's actually some varying opinions, but it's changes in retinal blood flow causing and then endothelial damage. And there's some hormonal factors as well, especially human placental lactogen. And then this picture here, you can tell grossly abnormal. There's a whole lot of neovascularized tissue here around the nerve. So it's great if these patients can be seen once before pregnancy, and then ideally the first trimester. And then they would be followed up depending on how much diabetes was affecting the eye. Treatment on our retina folks do this would be laser. Nowadays, if somebody does, a general person had proliferative diabetic retinopathy, we're actually doing a lot more of our anti-VEGF injections to help to decrease that neovascularization process. But with a pregnant person, you know, it does cross into the placenta. So unless there's some true sight-threatening emergency, probably would be laser treatment or else a surgery. So just briefly, a few changes during pregnancy. The cornea changes a lot, so you know, you wouldn't get LASIK surgery or fit contacts or glasses during pregnancy. The cornea swells and changes the refractive error. You can get decreased intraocular pressure. You can get worsening of diabetes. You get improvement if you've had long-standing uveitis, and then there's the preeclampsia and eclampsia overlap. All right, so these are true eye emergencies because we've got like 7 minutes left, so I'll try to whiz through these. So we've got our nice 78-year-old female. She notices some intermittent blackouts of vision in the left eye for a few weeks. She's got a headache. She thinks she's lost weight. Her head hurts when she's trying to comb her hair. Her exam is totally fine other than she's got decreased temporal pulses and some tenderness when you push here. So we've got a few slides on monocular visual loss because this is really important. So most commonly, you know, you could have an amaurosis fugax. You could have an ischemic optic neuropathy. So that would be where patients often wake up and they can't see from one eye. And that's usually in patients that have diabetes or hypertension. You could have bleeding from some retina problems or optic neuritis. Even a migraine can do it. Chronic causes would be glaucoma, chronic detached retina, diabetes, and some other retinal problems. So this patient has giant cell arteritis. I'm sure you guys know this well. A few things, they often, that is not asked, a lot of times patients, if they're going to have eye problems, they'll note that they had dimming of vision or transient obscuration of vision before, like a month before. So you can always ask about, do you have any blackouts of vision? Then they definitely would want to be treated and have us take a look. And then the most feared complication is something called, it's got a long name, we call it AAION, but it's basically an ischemic optic neuropathy, and that's irreversible. And if a patient gets that in one eye, there's almost an 100% chance it'll affect the other eye if it's not treated. So there are patients that are walking around that are blind in both eyes from this. So anybody that has giant cell, even suspected, I would start them on high-dose steroids and have us take a look if there's any visual symptoms. The exam, it might be totally normal. When we see patients that are normal, and the only thing they have is like a headache. They're very grossly positive on review systems, but their eye exam is totally normal. Other times people will have the afferent pupillary defect. If you look at the nerve, there'll be some chalky white disc edema. And there's also, in 10% of people, can have a central retinal artery occlusion. That's with the classic cherry red spot here. This is all just from ischemia because there's been infarction of the ophthalmic artery or the central retinal artery. There's a diagnostic criteria. It's really still clinical. And like I said, I would still start them on steroids, and we're happy to take a look if there's any concern for eye symptoms or you're not sure. And also some of you guys have already ordered the SED rate and the CRP, and that's really helpful too because somehow the labs sometimes get to us and back and not to you guys. So 78-year-old lady with some pressure like headache on the right side. It started very suddenly when she was watching TV. She's throwing up and she can't see. And on exam, her pupil, as you can see, there's injection. The pupil is mid-dilated. If you check the pupils, it won't react at all, or it will be very, very sluggish. And then the pressure is 60. And if you can't, obviously, if you don't have the tonometer, you'll be able to tell by pushing kind of on the outside of the eye that it feels more firm on the eye that's 60. So briefly, there are many mechanisms for acute angle closure glaucoma. We kind of break them down in our heads into things that pull the lens and the iris forward to block the angle drainage here, or things that are pushing it forward from behind. So there's some retina problems that would cause it to get pushed from behind, or even a growing cataract, which is really common. Basically what happens is this whole lens iris diaphragm is crowded here, and the aqueous humor cannot drain back into the angle. The pressure builds up. It causes people to vomit, get nauseated. The cornea swells. So the risk factors are things that cause this front part of the eye, this angle, to be crowded. So cataract. Women are more common to have this, more likely to have this because their eyes are just a little bit smaller. If somebody is hyperopic or their prescription has a plus in front of it, the eye is just shorter, so things are squished. Age, some ethnic populations, just the way that the eye is configured, it has higher risk. Like, for example, in China, there's no open angle glaucoma there. There's not none, but it's like 80% of closed angle glaucoma. And this can cause blindness. So I don't know if this would come to your office, but if you're not sure and their eye feels hard and they have these symptoms, we'll definitely take a look. Then lastly, this probably would come more to the ER, but lady's down and she's got a retrobulbar hemorrhage here. So this is our third true emergency, and the blood accumulates in the orbit, squishes the nerve, and it can cause permanent visual loss. And they need an emergent decompression of the orbit, a lateral canthotomy canthelysis. So this might probably come more to the ER, but I've actually been amazed. I had actually one guy from Intermed like 9 months ago that I actually, like, we sent him right to the ER. He was fine, but anyway, this is an emergency. I think that's it. Hopefully you got something out of it, but yeah, so usually it's older patients. They get up in the middle of the night to like go pee, and they fall, and that you have to really got to hit the area pretty close around the eye. And they're often on Coumadin or any kind of blood thinner. Even like a 325 aspirin can do it, and it'll be pretty immediate, and they'll have, vomiting, pain, loss of vision. They can't move their eye. The pupil response will be abnormal. So these ones are probably better off going right to the ER. And the ER here is pretty amazing. They've actually called me and said, we already did the canthotomy canthelysis, and they're saving people's eyes all the time. They're doing a great, at least I found they do an amazing job treating this, because it comes in a fair amount, and they'll get a CT as well. So, yeah.
Big question.
Oh, go for it.
Patients come in and complain of shooting pain in one eye that goes away.
That's a great, so shooting pain, so anytime that it's sharp stabbing or shooting pain, it's usually dry eye. So one thing you do is dry eye is often worse in the afternoon when our eye's been open more. So you can ask, when does it happen? Is it more in the morning or the afternoon? If it's in the afternoon, it's probably dry eye. It's really common. So you could try some artificial tears. Usually it's both eyes though, but sometimes depending on, the eye dominance, they might notice it more in one eye. You could try the fluorescein staining. It might be harder without the slit lamp to see it. You could try some tears. If it's not getting better, then we could take a look. If the dryness is worse when they wake up, they're probably sleeping with their eyelids a little bit open. So you could have their spouse spy on them and see if they have a lot of people sleep with their eyes like a sliver open. If that's the case, I would do like an ointment, like Refresh PM or Genteel at night. If they're a fall risk, though, don't do the ointment because I did that once. Not a good idea. So Yeah, the ointment is really blurring. Yeah, so if they get up a lot, then I would not do the ointment at night. Just tell them to put tears in the morning. And if it doesn't get better, we're happy to take a look anytime. Yeah. So, yeah. Any other questions? Okay. Yep, thanks.
Thank you. You're welcome. Great, thank you.